Hello, everyone. Thank you for joining us this evening to discuss this very timely topic, ambulatory anesthesia in the COVID-19 era. For those of you who do not know me, my name is Basim Abdimalik. I'm the current president of SAMBA. I'm professor of anesthesiology at Cleveland Clinic in Cleveland, Ohio. Well, if you're not a SAMBA member yet, I'd like to encourage you to consider joining us. Please visit our website at sambahq.org, where you're going to find a lot of membership benefit. I hope you'll find those attractive and you will consider joining us this year. Before we get started, I would like to go over a few things. First, I'd like to share with you that the SAMBA leadership has put together this COVID-19 resources webpage on our website, again, sambahq.org. Over there, you'll find a lot of links that I hope you'll find helpful. As you know, this is a fluid situation, and we're getting information every hour or so, and we try to keep up with it. We put a lot of resources there. If you go there and you see something that's not there, or you know a resource that you think would be helpful to our colleagues, please send it to us at info@sambahq.org, and we'll be happy to put that up there for you. You'll also find there an open discussion forum that we put together where we can engage with each other and we can share thoughts, ideas, best practices, as well as news, what's going on in our world and so forth, so we can help each other out, support each other out, and advance patient care, advance the profession and the specialty. Before we start this webinar that we put together for you, and I really appreciate you joining us in such a short notice. We all know its situation is kind of hot at the moment, and we'd like to go over a few things with you in that regard. In this webinar now, each of you will have a control panel, could be found in the right upper corner in your screen. For the most part, it will be in listening mode only during the presentation, and then after that, for the question and answer session, we'll have it open. We do encourage you, though, however, to enter your question in the question box if you have any questions during any time of the presentation. And we'll get that after the slide presentation. We'll have a chance to answer those questions and those that we have received already. In the chat box there, please post any comment that you wish to share with your colleagues. And also, if you have any technical difficulty, if you could put that in there, our staff will be monitoring that and will be able to help you immediately. I'm very pleased today to be joined by two panelists, Dr. Bobby Jean Schweitzer, Professor of Anesthesiology, University of Chicago. She's also the SAMBA Vice President. And with us as well, Dr. Leo Rodriguez, who is the SAMBA President-elect. He has been the Medical Director of the Ventura Surgery Center since 2008. Dr. Rodriguez, I would like to thank you because you, in such a short notice, prepared this great presentation for us. So without any further ado, I'd like to introduce to you Dr. Leo Rodriguez, who's going to be talking to us about COVID-19 and ambulatory anesthesia. Thank you. Leo, you have the screen, please.
Thank you very much. Good evening, everyone. I am not a professor of anesthesiology. I'm a private practitioner. I practice anesthesia in a freestanding ambulatory surgery center, but I also participate in organized medicine. So I'm part of Envision Physician Services. I'm the Assistant National Medical Director for Ambulatory Anesthesiology. And our company has many contracts in surgery centers of different owners of surgery centers. And so I have a lot of interaction with medical directors, executives, vice presidents of different companies. And this has helped me build this presentation because we're all trying to work together to help each other out during this time of crisis. And so right now, the big news is there is a nationwide elective surgery restriction. And people are asking why. We're getting a lot of questions. Why are we restricting ambulatory surgery? And how long is this going to go? The answer to that question, we don't know how long it's going to go. We can tell you that about 20% of infected patients with COVID-19 are going to require eventually hospital care. And in the United States, there's approximately 2.8 hospital beds for every 1,000 people. That's about a million beds in the United States. And we also know that there's about 3.6 ICU beds per 10,000 people. And what the government is trying to do, because we have such limited resources, is to create a program of social distancing. And by doing that, we're going to spread the infection rate to a slower rate, and this will allow the government to provide healthcare to people in a easier manner than if we suddenly get a peak. So if you look at the graph that I'm showing you here, in the dark purple, you'll see what would happen if anybody was out and about and doing everything that we do on a normal basis. And on the bottom, on the striped graph, it's what the government is looking for. By social distancing, we are reducing the rate of infection, and thus we're making it slower, the rate of people needing hospital care. Finally, I have to say that the medical director of a facility is the leader of an ambulatory surgery center. And not only we have to look out for the patient safety and quality, but we also have to look at the staff safety. And this is why it's so important, because we have to deal with both aspects of this problem. The other thing is that the United States has a shortage on personal protective equipment, and by slowing down the rate of infection, we are able to provide more personal protective equipment to providers in different areas as the infection rate increases, rather than everybody needing that equipment on a 2-week basis. One of the most important things that you have to do is to screen patients. And this starts from the surgeon's office. From the moment a surgeon or a proceduralist, whether it's a gastroenterologist, an ophthalmologist, they see a patient, they have to be screening the patient at their office. Have they traveled to level 3 areas? Have they been in contact with other people that are infected? Do they have fever, or do they have symptoms of upper respiratory tract infection? I recommend that you put signs such as this outside your surgery center, in the front door of the building where your surgery center is located, and you post in the bottom your number. And if people have symptoms, they can call upstairs, and one of your staff members can screen the patient and prevent them from coming into the waiting room and infect other people if we suspect that they may have it. Just yesterday, the American Society of Anesthesiologists, in combination with the American College of Surgeons, came out with a statement. And this statement says that we have to triage patients prior to being booked. So not only prior to coming to the procedure, to have a procedure in the facility, but they should be being screened in terms of what surgery they're having done by the surgeon, and not allowing some surgeries to happen. I posted the link here in the top side, but basically you can log on to the ASA website and look at the news, and this is from just yesterday. There is a link down here that talks more about the triage. It will take you to the American College of Surgeons website, and this is important because what they want us to do is to determine what kind of surgery the surgeon is planning to do at your facility. And what they're doing is they're using the CMS classification. This was produced by the University of St. Louis University, Dr. Samir Siddiqui, and he classified the urgency of procedures in tiers, and they have a tier 1A, 1B, 2A, 2B, and then so some are low acuity, but in a healthy patient and an unhealthy patient. So patients that are basically going a low acuity surgery, they should not be done at this time. These are patients that they can wait to have a procedure at a later time. These are some examples that they posted. There are some other patients that there are some concerns, like having cancer, and they need further diagnosis or treatment, and those are appropriate. So if you want to know if a procedure is appropriate to be done, you're going to click on that link on the ASA website, and this is going to pop up. So on the left side of my screen right now, you see something that says COVID-19 elective case triage, and this is actually a manual that was produced by the American College of Surgeons, and it goes by specialty. It goes from surgery, gynecology, every single specialty, and it tells you what cases are semi-urgent or urgent and what cases can be deferred. And I put example here on the right side of my screen. You have, for instance, breast cancer surgery, and these are the samples of procedures that are appropriate to do at this time where we're trying to suspend the doing elective surgery. And then in the bottom, you have surgeries that are not appropriate to do at this time and that they recommend deferring. Because remember, every time you do a surgery, you're bringing somebody to a healthcare facility. They themselves can be infected and they can propagate an infection to somebody in the facility, and also they can be infected by being in contact with somebody else that is at the facility with the bacteria. So one of the initiatives that we're recommending people do is to have a surgical or medical justification form. I posted a sample here on the right side. And what I recommend everybody does is that when a surgeon is trying to book a case, aside from sending a booking sheet, they should write their name, when they're going to do the procedure, what procedure exactly they're doing on what patient, and then they have to determine, based on the knowledge that I just gave you from the American College of Surgeons, they have to determine if the procedure is urgent or semi-urgent, and they have to state what would happen to the patient if they don't do the procedure. Why can the patient not be delayed? And another thing that they want us to do is to make sure that surgeons are discussing with patients the fact that anytime you access a healthcare facility, you increase your chances of being infected with COVID-19. And so in this statement, we cover everything that they want us to do. Aside from that, so let's say we approve the procedure, the case is going to be booked, and the patient is going to show up to the facility. So now we have a pre-op nurse call the patient, and aside from doing all the preoperative information that we gather in the pre-op clinic to determine if a patient is appropriate or not for a surgery center, we're also going to classify what is the risk of this patient of being infected with COVID-19. So we're going to classify based on symptoms, on contact, on travel. And so we're going to ask the patient, have you traveled to a level 3 area? And we have a map that changes every day. Have you been in contact with somebody that is positive? And do you have any symptoms or not? So if the answer is no to all of those, it's a low risk patient. If they're in a high risk area where they may have been exposed, they're considered at immediate risk, even though they don't have any symptoms. And then high risk is when the patient is actually showing symptoms and they also have all the history. And here's a reference where I got this information from. So I created an algorithm to facilitate the things that need to be done. So the first thing in the top is to determine if a case is urgent or semi-urgent. And I remind everybody again, no elective cases at this time of what we're going through. The second thing is the patient a candidate for the ambulatory surgery center? If the patient is an ASA 5 that needs a heart transplant, obviously it's not a candidate, so it should be done in a hospital. The third question is the screening questions. So we do this by phone the day before surgery, and we also do it the morning of by phone and when the patient arrives. We have a staff member in our facility with a clipboard, and they have protective equipment, and they're asking the patients all these questions to allow them to proceed into the waiting area where they're going to check in at the facility. So at this point, we're going to determine if the patient is low risk, and if it's not, if it's a low risk, then we're gonna proceed to admit the patient. And then the next thing is if this is an aerosolized procedure or not. So if it's an aerosolized procedure, meaning an upper endoscopy, a procedure in the airway like a direct laryngoscopy or a laser or vocal cord or tonsillectomy or bronchoscopy or something like that they want to do, those are procedures that increase the risk for the healthcare workers. So in theory, if the patient is completely low risk and they can wear a standard protective equipment, but if the patient is moderate risk, they should wear an N95 mask or equivalent with the personal equipment. If the procedure is not an aerosolized procedure, then the staff can wear standard personal equipment for protection and a standard OR mask. I want to highlight, because I get this question every day, because I'm on the phone about 6 to 8 hours a day answering questions to people. A routine intubation, extubation is not considered an open airway case. So that's a big question, because that's in the APSF ASA combined guidelines. The second thing is that the CDC has details about what is the appropriate mask and what the appropriate personal protective equipment. And I placed a link down here in the bottom of my screen. You can click on that link, and it gives you the recommendations from the CDC. If you have a surgeon that gives you a hard time, even though you have the American College of Surgeons website, every single society that I list here are the ones that do procedures in ambulatory surgery centers. They have a statement about the COVID-19 crisis in which they tell people don't do elective surgery, and they go into a little bit more detail depending on what they're doing. And these are samples. Ophthalmologists, they say don't do, delay elective surgery. Same for orthopedic surgeons, they're recommending delaying elective surgery and so on. I'm not going to go over every single society. So, when people when people need care, there are emergency surgical situation, and then the hospitals, they do exactly the same thing that we're doing. We're triaging patients, and they proceed to surgery if they're not suspicious for the COVID-19, and if they're suspected, they're looking to see if it's more urgent or not, and they have their own algorithm. So
Hi, Bob.
this please mute your phones. I can hear. Hello? I don't know if you can mute everybody, Mallory. Okay. So for GI procedures, so there's an algorithm. This is a reference from the gastrointestinal endoscopy. I get a lot of questions about that. We're going to screen the patients again, and we're going to determine if the patients are low risk or high risk. If they're high risk, we're not going to do these patients in an ambulatory surgery center. If they're low risk, we are going to do it. And again, if it's a 100% verified low risk, this is a 70-year-old person who's been in their house for 14 days. They haven't had contact with anybody. They haven't traveled anywhere. It's okay to do with a regular mask, because you're not gonna get infected. Now, when you're suspicious about the person, so let's say that you're encountering a teenager that has been out and about. They're there with a parent, and the parent's going to tell you that, oh yeah, he's been out a few times. So we consider this patient moderate risk. So if you're doing an upper GI endoscopy in that patient, you should wear an N95 mask to protect yourself. If you're just doing a colonoscopy, then you can just wear a regular mask. And this is a very descriptive with pictures and the same algorithm, but this is summarizing only when it comes to the personal protective equipment. If you are going to manage a patient in a hospital, I made this just to remind everybody that if you need instructions of what you need to be doing, the APSF has clear instructions of what things you need to do when you're taking care of a patient that, in this case, it would be a moderate risk patient, how you're going to take care of that patient. And you can go to the apsf.org, and then you click on the COVID-19, and it'll take you to the page where this poster is posted. One of the most important things that we can do is hand washing. So at our facility, everybody's washing their hands, I think once a minute, probably. We're asking the patients to use the alcohol-based solution as soon as they walk in. We take them to a sink. They wash their hands with water and soap. The same for the nurse. We sit down. We do the pre-op workup, and then we wash our hands again. We sit the patient. We do the vital sign. We wash our hands again, and we keep using the same cycle that we normally do for hand washing. When it comes to personal protective equipment, there is a severe shortage in some areas of N95 masks. And so some people have developed an off-label use of equipment from the operating room to create something that is actually better than an N95 mask. There is a video on YouTube. I posted it here, and I put the link of the video right here. And later we can go over it if we have time. But I recommend that you sit down and you observe, because actually we've done this in our facility when we're doing moderate risk procedures and when we're doing airway procedures in the facility. And we, for the past 2 weeks we've been doing it. Nobody has had a fever or anything like that. Um, so what we're doing is we're using an anesthesia machine filter. So this anesthesia, there are many kinds. This is one of the vendors that sells this kind of filter. And basically, it's a 99.9999% filter. Filters out viral particles and bacteria. And I like this one in particular because it has a port for CO2. Because this is something that comes up that when you're putting a patient to sleep, a lot of people connect the CO2 to the L-shaped connector here. And then that air is going into the anesthesia machine with the little hose, and the sampling line samples the CO2, and then it can go into the rebreathing of air. So I like using this because I'm protecting both the CO2 line and the anesthesia machine from a contamination. And again, this is off-label use, okay? This is a sample of people that did what the video shows. So basically what we're doing is we're putting an OR mask on yourself. And this is if you have a shortage of N95 masks and you need to do a procedure in which you want to protect yourself, like the moderate risk procedures, okay? And you got OR mask, you take the green strap of a oxygen mask from the recovery room and you tie it to the circle ring that we use for the black strap of the anesthesia mask in the operating room. And that's how you anchor the mask to your face. You're going to connect the L-shaped connector to the mask through a regular level 3 mask. And then here you're going to have the filter of the OR machine. And what you're doing is when you breathe in, no particles of virus are going to be able to go through here. They're all going to be trapped on this side. You're going to breathe in and then you're going to breathe out. And then after you put this on, then you put the gown and the hat, and you're going to put a face shield on and gloves and shoe covers and all the other things that we need to do. If you don't know exactly, let's say that you have an N95 mask and they tell you, oh doc, we only have one N95 mask for you. So there are a lot of people out there advocating to reuse the N95 masks, and the CDC is saying that if the mask is acceptable, that you can use it. One thing that we're recommending is that if you do have an N95 mask, that you wear a level 3 mask on top of it to prevent soiling of the N95 mask. Again, when you do this funky off-label use of the OR mask with the filter, you're also going to cover it with a level 3 mask to protect it from being soiled. And then there are different methodologies that they're mentioning about how to reuse the N95 mask. And this something I found from Dr. Peter Tsai, who was the inventor of the material inside the N95 mask, which is actually polypropylene. And he's saying that the mask should stay dry, so that a single provider should have at least 4 masks, and you should label your masks as 1, 2, 3, and 4. And then Monday you use mask number 1, on Tuesday 2, 3, 4, and then on Friday you go back to mask number 1. And otherwise you should let them out in a dry room to let it dry out. And by being dry and by extensive time, the viral particles cannot survive that long. So you're allowing atmosphere to get rid of the virus. Another thing that can be done is to put it in an oven, and here are some instructions of what to do to warm it up. However, I have to tell you that the metal piece of the mask can get detached from the mask itself, so it might lose some of the protective qualities of the mask by doing that. So I recommend that less. However, if you go into the 3M website, it's going to tell you in a memo written just this week, March 20, 2020, that they do not recommend sanitation, disinfection, sterilization of the N95 mask. You can look it up. You can look up this memo Just go to the 3M Science Applied to Life Technical Bulletin, March 20, 2020, and you look for disinfecting, filtering face piece respirators, and it will take you to the link. It's very extensive, and they talk about how ultraviolet light can damage the polypropylene in the N95 mask by oxidizing it, and then it loses the electromagnetic properties, which is one of the things that rejects particles from being going through the mask. And so it loses a lot of properties, and it tells you about everything. It tells you when you warm it up, this happens, and when you do this, it tells you everything that can happen to an N95 mask when you're trying to reprocess it. Now, another thing that's interesting. So let's say that you did a case in your facility, and the patient on a post-op call 3-4 days later, the patient tells you that they tested positive for COVID-19. So before he was low risk or she was low risk, and now they had the surgery and they left your facility and now they're testing positive. So then, the recommendation is to find out if there was an exposure of the healthcare workers that dealt with the patient. And then if the patient was wearing a mask during the entire time, so let's say that you were in the one to colonoscopy and they used a face mask, and so it's less likely that there was an exposure of the healthcare worker. If it's an aerosolized procedure like the ones I mentioned before, there is possibly an exposure of the patient, of the healthcare worker. So the recommendation is that the healthcare worker can return to work, but they have to be wearing a mask and they have to monitor their temperature and symptoms at all times on a daily basis for 14 days. If the patient, it was an aerosolized procedure, and the healthcare worker was, the next question is, did the healthcare worker wear a mask? And if it's yes, it's low risk, so there's no problem. Now, if the healthcare worker, it was an aerosolized procedure and did not wear a mask during the entire time, it is recommended that the healthcare worker go into quarantine because they were most likely exposed to the N95 virus. There are some best practices that I wrote here on the slides. One of them is that some facilities are now recording the temperature of every single employee when they arrive in the morning, and they keep a table of it with the names of everybody, just to know if there's a change between one day to another. And another question that comes up a lot is, oh, I was in China last week and I sneaked into the country. Can I come back to work? And the answer is yes, they can come back to work. However, this person has to have a mask on the entire time and they have to self-monitor. So it's different the way we manage patients than the way we manage healthcare workers, because we need healthcare workers to be working. In how to wear the personal protective equipment, I have put posters here from the CDC. This presentation is going to be on the Samba website, by the way. And it explains in English and in Spanish what steps you should take when you're wearing your personal equipment. I always recommend that people wear double gloves, and then how to take it off. It's also very important. You take the outer glove off first, and then you take all the other equipment, and last you take the glove off and the mask and the last glove. And explains everything. So in my next slide, I also put another YouTube video. This comes from England. And as you know, in Europe, they've had a lot of COVID-19 exposure. And I have the link here. And they did a simulation of how they prepare to do an intubation of a patient with a confirmed case of COVID-19, how they prepare the room, how they dress themselves up and they wash their hands and everything. They put the equipment on. And then once they intubate the patient, how they manage the equipment after the intubation, and then they show you how they take everything off and they wash their hands, etc. And then lastly, you should visit the APSF website, where they give you tips on how to protect your anesthesia machine from contamination, and also how to decontaminate the anesthesia machine. It's a very long information, but I'm giving you the information here, the link, so that you can go visit and do it with your staff at your facility. And I'm going to stop talking now. I've been talking for 30 minutes, and I'm going to allow for questions.
Thank you, Dr. Rodriguez, for this very informative presentation. We really appreciate it. A question came in earlier during your talk. I think they may have gotten the answer now, but I'm going to go over ahead and repeat this. It wouldn't be better to postpone such elective cases and save staff and equipment? And I would say absolutely. I would like to reiterate that message again. Please cancel all the cases that you can. Only restrict your practice to urgent and emergent cases. For now, God knows if things get worse. I hope not. I pray I hope not. But if it does, we may have to revert to only emergency cases. I think the idea here is to, when we do these urgent emergent cases, we're offloading the bigger hospital to allow them the opportunity to take care of the critically ill patients and those of COVID ICU worthy patients that need to go to ICU and require all these resources and protective gear and so forth. So that would be one of our contributions to the profession at this time. However, things may get worse and they may have to require to transform big ASCs into COVID units or ICUs and such. Small ones may not be practical to have 2 or 3 rooms ASC to be transformed into ICUs because lack of the backbone supplies like pharmacy, pumps, and this and that. But it might be at that point there might be a need to move some of these anesthesia machines into area in the hospital where it was designated to start building an ICU, as well as a makeshift hospital nearby. So these things or this option may happen. I just received information that in some areas in New York, they already transformed some PACU into ICUs, and they have moved some anesthesia machines outside of the operating room to be used as ICU ventilators in those areas. I heard some information in Louisiana, and these are 2 of the big hotspots right now, Louisiana and New Orleans, as well as New York. In Louisiana, they made a makeshift ICU, and it's already filling up with patients. So I hope these are only the hotspots, and this doesn't spread around the country. But if so, we need to be prepared. So one resource we offer in our website is a sheet provided by the Ambulatory Surgery Center Association, where it gives you an opportunity to go over your inventory as a ASC, look at the personnel, the equipment that you have, how many anesthesia machines, how many pumps and such, how many nurses, how many the personnel-wise, how many nurses, how many anesthesiologists, how many administrators, how many techs, and so forth. And also what are other things that could be used in case of emergency, like PPEs and other surgical equipment and such. Once you have that inventory ready, you'll be ready to be mobilized when the call comes in from your county, from your community, from your state, that your resources are needed to help the community. We all need to be prepared to help our communities at the time of need. Some states, like in my home state in Ohio, the Ohio Department of Health already started mapping out ASCs and collecting information on those resources to be ready and available if the illness is spread in a way that we're going to need those resources. With that, we'll start going over some of the questions that we received from you. The first question says, how long do we think we at surgery centers will be closed, and what decreases in COVID will be needed to start up and precautions to be taken? So in other words, when do you think we're going to get back to business? Leo or Bobby?
Nobody can answer that question, to tell you the truth.
That is very true. I think it's a difficult question. I think we're going to have to wait and see how things progress, and if this social distancing is effective in so-called flattening the curve, and see how that goes. At that point, you all heard the your Governor Cuomo, and the President of the task force talking about how they wish to see things back to normal by Easter. Obviously, we all hope that this would happen even before that, but it's conditional depending on what happens with illness and spread and so forth, and the effectiveness of the measures that are being taken right now. Thank you.
Yeah.
The next question is
I wanted to add something else. There's a question there from Bobby Jean about this, and is New York considered a level 3 area? So New York is a high risk area. So it's New York, Washington State, and California, especially San Francisco, those areas. And interestingly, they have not called a level 3 any area inside the United States. They're just calling areas outside the United States level 3. Um, in Florida today, the governor issued an executive order prohibiting people from New York to come to Florida. So they're actually, if they come, they have to quarantine for 14 days in the state of Florida, New Yorkers. Go ahead, Bassam.
Just
Thank you.
to add to that, if you don't mind, this is Bobby Jean. To add to that, Dr. Birx, who is the White House spokesman, has urged everybody that is traveling from New York to quarantine for 2 weeks. So even though they haven't declared that, I do think we should be concerned. And perhaps people want to add that question, specifically if they're within the area where they anticipate people to be coming from New York City or New York.
Excellent comment, Bobby Jean.
Thank you both. The next question says, is an N95 mask required by the anesthesia personnel during intubation of the low-risk COVID-19 screened patient who is having a non-elective procedure in an ambulatory surgery center?
The answer is no. So
Leo, so ASA just came out on Monday saying that they do recommend that. It's a joint statement with the American Association of Nurse Anesthetists and the Anesthesia Patient Safety Foundation. It's on the website asahq.org. It's dated March 23rd. And it specifically talks about how, people can be asymptomatic and still be COVID positive. And typically they are asymptomatic for the first 5 days of infection. And yet it's transmissible during that time. And they recommend that any anesthesia personnel managing airways use the most protective masks.
yeah, so remember, you have to protect your staff and yourself and your patient. So there was a lot of discussion between the ASA and the ANA, especially over this topic, because the ANA was a little bit more aggressive recommending it, and the APSF and the APSF guideline, because that's the citation. It talks about the open airway case. I have it here in the box in this slide, on the right side on the box, and it's not classified as such, but to protect your staff, yes, I would do it. I recommend that if you don't have N95 masks, I would go to this off-label use. Again, this is a very nice video, and it will show you how to do it.
All right, thank you both. The next question would be is, I'm wondering about servicing infertility practices during this time of equipment and supplies rationing. I understand continuing with cases like oocyte retrieval for women who are already in the pipeline of triggering, but doing new cases, these cases seem to be totally elective to me. So it seems like this person is looking for help and support in his decision. What would you say, Baba Jean and Leah?
Well, our institution has canceled all new fertility treatments, except for situations where they're trying to preserve fertility in women with recent diagnoses of cancer, who cannot wait to, preserve their fertility. But otherwise, all elective fertility cases have been canceled. And I've heard other institutions are doing the same thing.
Have anything to add, Leah?
No, that is correct. There has been some discussion on patients that right before they started, they already were taking the hormone injections and they were about to ovulate, and some procedures happened, but that it's been already almost 2 weeks, so that's not going to happen anymore. And I agree that these should no longer be booked, those type of cases, because they're not urgent.
The next question we received is, what is recommended for MAC cases going forward, as well as mask cases?
So again, what we need to do is we need to screen the patients and to determine if they're high risk or low risk. And then based on that, you make your decisions about how you're going to protect yourself. You remember that you're doing procedures that are semi-urgent and urgent. It's not like you're doing elective hernia repair in an ASA1 patient just because they want to do it. Is you're doing procedures that the patient needs based on the list of the American College of Surgeons. And I would still continue doing MAC anesthesia on the patient. If you're very concerned, you can always put a nasal cannula and then cover the patient with an N95 if you had excessive amount of N95 or a level 3 mask to prevent aerosolization of particles from the patient. But in reality, if it's a real low risk patient, it should not be a problem to do a MAC procedure. Anything different to answer, Bobby Jean?
Again, I would urge the providers themselves to wear N95 masks during those procedures. Because, nasal cannula is going to basically be an aerosolized situation. And again, based on what the ASA in conjunction with the AANA and the Patient Safety Foundation has urged that all patients must be considered at risk for having COVID, that there's really no effective way to screen patients. And even, having a negative test doesn't absolutely guarantee that the patient's negative. That they do present a diagram saying that if the patient has a negative test for COVID, they don't give a time course for that. So that's concerning, because if you had a negative test 2 weeks ago, is that still valid? I don't know. But they debunk the whole idea that we're able to really, at this point, based on history alone, categorize patients low risk enough to consider them safe and not protect yourself if you're managing, quote unquote, their airway.
Okay. There's another question down the same lines. What can you share your thoughts about outpatient EGDs without intubation and provider protection?
Well, provider protection you do have to use. So again, if it's an upper endoscopy is an aerosolized procedure. First of all, it has to be very justified. If you look at the tier procedure list from CMS, that's a tier 1A if it's a healthy patient, and 1B if it's a sick patient. So the recommendation for those procedures is to reschedule a later time. But now, if the patient has severe dysphagia, and that will be one of the diagnoses where the patient would be okay to proceed, then you do have to protect yourself, and because it's a moderate risk, then I would use an N95 mask and all the personal protective equipment. We should not be denying care to a patient that needs it just because I don't want to get infected. We're doctors, we're not laypersons, so we sacrifice a lot, and that's part of our sacrifice to take care of patients. We just have to protect ourselves correctly and then do the case.
Thank you. There's another question to talk about regional anesthesia. Any special precautions for regional anesthesia at this time? Should regional anesthesia be done in the OR now, or is pre-op okay, considering we're giving sedation? Any thoughts, please?
Well, there are different ways of doing this. So I am a minimalist. So I usually, when I do regional anesthesia, I'm a talker. So I distract patients, and I try not to use sedation when I do regional. I just use my local, and I talk to them. If I'm doing sedation, I'm going to do a mild sedation with Versed. Again, if you're going to use the nasal cannula, like we mentioned before, maybe you should do it in the procedure room, like it was mentioned. I don't think that there is any additional precautions that you have to take, because you have to protect yourself and then do the procedure if the patient really needs the procedure.
Thank you. If I may add, um, if you're going to do regional anesthesia, most of the time in OR, we end up using sedation with that. Just be mindful that you will not be able to use heavy sedation, because if you use 1 or 2 layers of cannula, that's one thing, versus use 5 or 6 or 10, then you could aerosolize the viruses if they were there. In that case, you may want to choose a general technique to avoid doing that. And also remember, if you have to support the airway with a jaw thrust or something like that, you are 1 foot away from the face, increases your risks as well. So these are things to consider as you make the decision between regional versus general versus regional with heavy sedation or regional
Hello?
with no sedation or light sedation. So
Bassem, I lost your sound.
Okay, how is it now? Hello?
Now I can hear
you hear me?
Yeah, I can hear you now. Yeah.
Okay.
So I would
was
encourage
just
everyone,
mentioning-
I would encourage everyone to engage the patients in these conversations also about the risk and benefits. Because if patients can really benefit from a regional technique, then I think a conversation with them to talk about whether they need to have any sedation or not. You know, I think frankly, we use sedation often in situations where we don't need to use sedation. And especially if patients realize the, consequences and the risk, and if the difference between having to have an intubation and a general anesthetic versus being awake, or perhaps having just a little bit of Versed with your regional block, I think many patients may actually opt, for the regional and being wide awake or with minimal sedation.
Exactly.
So, yeah, so please have a conversation with your patients and explain the reason that, in this situation, we can't offer the sedation techniques that we would, do in a different circumstance.
Yeah.
Sure.
And believe it or not, you'll find out that you don't need to give that much sedation to do regional anesthesia.
We have another question from, say, the ASA and AANA have both made a joint statement saying that an open airway case should be avoided and specify this as a MAC anesthetic. I think we just answered that, but the follow-up the question says, should we be doing general endotracheal anesthesia for all cases, even a 15-minute lymph node biopsy or poor placement? I may add to what was mentioned earlier. Again, I just mentioned that I guess I lost the sound in there. That these cases, if you're going to be using heavy sedation and you're using high flow of oxygen, like 5, 6, 10 liters or so, that may aerosolize the virus. Or if somebody is sleep apnea and you may have to do some airway support maneuver like jaw thrust or some like that, you will be 1 foot away from the airway. In those cases, you may want to opt into doing general anesthesia so as you can avoid being exposed. Some more questions came in. So you're saying intubation and extubations are not considered aerosolized procedures. Same with hooded endoscopy. I totally disagree. This is not a good advice. This was comment from one of our attendees. What would you say to that, Leah?
So if you read the statement from the APSF, it says that they're not considered open airway. Now, again, you have to take care of your staff, and you have to protect yourself. So you should use the N95 mask if you feel that you need to use the N95 mask. So I'm not telling you don't do it. I'm telling you to use your judgment. So I have patients that are from the community. They're low risk. They haven't traveled. They haven't had any contact. There's a lot of lonely people here in Miami, and we have done the procedures and with a regular mask. But again, you have to do what you feel. So in our company, that's what we do. We tell people you should use a mask. However, if you feel that you need to use an N95 mask, we're not going to stop you from doing it or from protecting yourself. And that's why we created because what happens is in the surgery centers, the hospitals, they came around the surgery centers, the affiliated ones, and they took all their N95 masks over to the hospital. So there's a shortage in the ambulatory surgery centers of N95 masks. So that's how you have to make your decisions. So what will you need? And this is what we have done at my facility, and it's being done in a lot of places nationwide. The pictures that I'm showing you there to protect yourself.
I think what I'm hearing between you and Bobby Jean is that there's ideal situation, and there's something have to do with what we have and rationalizing things. So, ideal situation, if you have those masks available and so forth, it would be okay to use them. I would actually recommend it to use them. But in case if you have shortage of them, like everywhere around the country, so perhaps it would be better use of it in cases who are confirmed or suspected to decrease the chance of infection, and in those who are very, very low risk, no symptoms, no exposure and such, even though we know that they could be a silent carrier, but the risk of infection from them would be much lower than suspected or proven or confirmed infected case. We would be preserving those masks for those cases. But I wish if we all have plenty of them to use them in all cases, that would be the ideal and best case scenario to protect ourselves, because we start hearing some reports about physicians and nurses getting sick and getting admitted, and it's heartbreaking, and I do not wish to see that anybody, and we hope that we can continue to take care of ourselves to be able to be available to take care of others as well. I have another comment from one of our attendees. Says, if we lift the mask for a few days as you're recommending, would it pollute the atmosphere around it? If it is windy, wouldn't that risk spreading the virus?
So what they're trying to do, so what the recommendation from Dr. Tsai is that when you take the mask off carefully, you should put it inside a paper bag, and then you put the mask in a dry area and allow it to dry slowly through the papers. Don't put it in plastic, because then you're going to preserve the moisture. And one of the most important things for this mask to be effective is that the mask has to be dried. So the recommendation is to put it inside a paper bag and just leave it there in a dry area where there's air conditioning to allow it 4 days to dry. And by the end of those 4 days, the viral particles are dead, because they're not going to survive 4 days. They need a host, and the longest they last is up to 3 days, depending on the materials.
Thank you. We have a question and a comment, actually, interestingly, about the picture that you have up there with from your slides. The comment was, when I recommend when making an N95 mask from anesthesia parts, you should have it fit tested by a facility that offers this. The seal may be nowhere as good as you think, allowing the virus to be pulled inside. That's a nice thought and a comment. We appreciate that.
Yes.
The question regarding that says, when you say mask here on the slide.
Wait,
yeah, go ahead.
Bassem. So when you put a mask on like this, what you do is you put your hand at the tip of this or at the tip of this or the filter, and you take a deep breath, and you'll see the negative pressure on your face. You'll feel it, and that way you know that a mask has a good fit for yourself. That's the way they're recommending, and that's all in the video that in the YouTube video that I'm recommending that people watch, because I've practiced in war times, so I've been in situations where you don't have enough things, and you have to continue doing your work. So it's you have to improvise, and you have to do the best you can, and this is actually better than an N95 mask. Okay, continue talking, Bassem.
Oh, the question was, when you say mask here on the slide with the healthcare worker exposed, are you meaning regular surgical mask? They're probably referring to the left-sided panel. I believe this surgical mask is on top of a
Yes.
plastic
Yeah,
mask. Is that true?
yeah. In here, there's a level 3 mask, an OR mask, on top of this plastic mask. The thing is, I'm demonstrating different stages of how you would wear it. The reason for this level 3 mask is to protect the plastic mask from getting soiled. That's why we're doing that.
Excellent. I think we received quite a bit of questions, a good number of them. And this would be an opportunity for us to, we're going to put these answers together in a Q&A answer sheet or FAQ answer sheet. We're going to post that on our website. I also would like to know that the recording of tonight's webinar, along with Dr. Rodriguez's handout, will be posted on our SAMBA website. It's going to be on the COVID-19 webpage if you visit our website at sambahq.org. I was wondering if there's any last minute questions since we have 2 more minutes to go. If we get more questions, having seen none, I would want to close and thank you all for joining. I would like to say thank you to our 2 panelists, Dr. Leo Rodriguez and Dr. Bobby Jean Schweitzer. I would like also to thank our staff, Mallory Calderella, for taking care of all this work for us, as well as Monica Lumpy and Sarah D. We appreciate you. And I thank you all for joining us tonight for this. This is a tough time that we're all going through, and we all have to help and support each other through this time. Please join us at sambahq.org, and we'd love to have you there, and please consider joining our society. Please stay in touch with us. We might be able to do this based on your feedback. We're going to send you some email with all the links that we posted here, as well as we're going to have them on our website. And we'd love to have you back when we have our next webinar on this topic. Thank you, and have a good night.
Thank you, everyone.